Hello and welcome to Talking Meds, a podcast from PrescQIPP, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill, Medicine's Clinical Advisor here at PrescQIPP. Hello and welcome to this episode of Talking Meds. I'm joined today by Beryl Navti, and we're going to be talking about medicines optimization issues in the treatment of Attention Deficit Hyperactivity Disorder, or ADHD. Beryl is a consultant pharmacist for child and adolescent mental health services, so CAMS, in North East London NHS Foundation Trust, or NELF. So there's your abbreviations for the day. She works closely with pharmacy leads and a wider multidisciplinary team, looking after sort of aspects of safe prescribing, medicines governance, and medicines optimization for children and younger people who have mental health needs. So a challenging job in a tricky area that I suspect is quite rewarding as well. But Beryl has over 25 years experience of many sectors of pharmacy, including community, hospital, academic, as well as mental health sectors. And she's also currently the Registrar of the College of Mental Health Pharmacy, where she very much seeks to help pharmacy professionals keep up to date and be fit for the future of children and young people's healthcare needs. Beryl, welcome. Thank you so much for joining us. I'm really looking forward to this conversation. This is an area that I found interesting for a number of years, the management of ADHD. So what was it that brought you into this field? What was your background? What led you? What was your journey into this?
I mean, my background is as a pharmacist, as I said, spans 25 years. And for a long time, my involvement with ADHD was simply in the dispensing of the medication while I was a community pharmacist. And it was really about answering questions to families about their medication and talking to clinicians who were prescribing, ensuring that they were writing the prescriptions properly, with supply issues and things like that. But when I became a mental health pharmacist, which is around 16 years ago, I started seeing more and more patients with comorbid mental health problems as well as ADHD. But I did not actually start working with ADHD services until about 6 years ago, when we were visited with the COVID-19 pandemic. And one of the things as a lead pharmacist was to work with service leads to develop guidelines for clinicians working within ADHD services to support them with managing patients in an era where we had to maintain physical distance and diagnosis of ADHD. We had to come up with guidance around working virtually with families, physical health monitoring, because you require those tests in order to prescribe safely in ADHD. And so that led me to an era where I was constantly responding to queries from clinicians about their prescribing, what to do if monitoring tests had not been received, or what the red lines were and where they could sort of overlook certain things and continue prescribing. So I worked with that. And then we took over children and young people's mental health services in Kent. And a significant portion of that was neurodevelopmental services. And we were looking after and actively prescribing for thousands of young people with ADHD, because our service, which is a specialist service, held the prescribing responsibility for those young people. And I eventually started my own caseload with reviewing medication and optimizing treatment for children and young people with ADHD. And I have evolved from that over time, from being a clinician to working more strategically with services to manage those ADHD related services.
Yeah, I mean, people have usually got a personal story to tell around what brought them into their particular field. I know I certainly remember when I was way back at the old Westminster Children's Hospital, And we're talking maybe 25, 30 years ago now. And there were children, and there was a mental health service within Westminster Children's Hospital where they were looking after usually adolescents, actually, who had some sort of mental health issues. And it was ADHD was quite a new diagnosis then. It wasn't something that people were labeled with on a frequent basis, and there certainly wasn't a lot of treatment for it. I remember children being treated with sort of amphetamines as a sort of a way of managing their more aggressive and more problematic, troublesome symptoms. And I remember there was one lad in particular who I got to know, um, and was transformed actually by the care that was given to him. But it wasn't the medicines; it was actually the care and the attention that he was given by the carers, and his parents were given coping strategies and stuff like that. And I guess what I'm saying is during COVID, because there is a large component of care that requires face-to-face care for people with this. During COVID, that must have been quite difficult because you, as you say, you're at a distance and you've got to create nuanced services that perhaps aren't what you would ideally design, but you have to make best of the situations, don't you? And it sounds that's exactly what you did and led that
Yeah.
development very closely. So just in terms of the particular challenges around people with ADHD, and I think for their carers, what would you say were the particular challenges?
There are a couple of aspects to those challenges. The first aspect, as is widely reported, and as we know, is around identify and identification and diagnosis, and the service or system challenges around that, where we know that waiting lists are now ranging, waiting times to be assessed and diagnosed is quite long, particularly in NHS services, and even with private care services where the times are shorter, those waiting times are increasing. So, coupled with the fact that the wider awareness around ADHD due to social media platforms and a lot of people learning more about it while under lockdown in COVID, because for a lot of parents, I work with children and young people and their parents, and it was the first time that they were, exclusively with children in the house during school times during the day, so you could observe some of the behaviors, and the seeking of knowledge about how to manage those behaviors led people to realize that, okay, there was obviously something not right. And so at the influx of people wanting to be assessed, there was an increase in that, but then the limited resources to manage those waiting lists have meant that a lot of people have gone undiagnosed, which obviously increases the challenges. So that's the first aspect. The second aspect is really around people who are living with the condition, that have been diagnosed, their suspicions have been validated, and they know they have the condition, but there are ongoing challenges in terms of, executive functioning difficulties, planning your day, organization, time management, initiating tasks, particularly tasks that you find boring. I think one of the times that a lot of adults realize that they might have ADHD is when they struggle to actually initiate and start tasks or finish them. You know, that's a problem. For ethnic minority people, ethnic and minority backgrounds, the stigma particularly in those demographic, is still quite huge, where many people still believe that ADHD doesn't really exist. For children and young people, it's poor parenting, and for adults, it's an excuse not to do the work that you're supposed to do, and which can be challenging for people that know that something is wrong. It's not a condition that you're making up. It's something that you're living with, and your struggles are very real. And then the other challenges include coexisting conditions. So the statistics are that a lot of people with ADHD have comorbid anxiety, they have comorbid low mood, and for many other neurodevelopmental disorders like autistic spectrum disorder. And what that means is that often, even when you've been initiated on medication, you have side effects of the medication, and you're unsure whether, it's because you have other mental health problems that you're not exactly getting the best out of your treatment, or it is because of the side effects for the treatment that you're receiving. And that's a challenge for the person suffering as well as the clinician that is looking at them, trying to balance the difference between treatment not working and other comorbidities that may be influencing response to treatment. And I've also usually talked about the late diagnosis and things like that. And then inherent to ADHD is adherence to treatment, particularly those that are counting as adults but are actually young adults. So they've just started university and then they found out that they've got ADHD. I have personal experience where a family member starts university. They've come from a very structured environment, boarding school environment where they get reminders about everything, and then they go into university and suddenly they start struggling, getting themselves to lectures and stuff. And then they're diagnosed with ADHD, and then they have to remember to take their treatment, remember to attend appointments for review. If you don't attend appointments for review, your meds get reduced and stopped. And so that's a challenge for people who now have to learn to manage every aspect of their life and not just medication for treatment. For those that are carers, really, you're thinking about those who are looking after young people with ADHD. Behaviors can be challenging, and medication doesn't always solve those problems. And then those that are in schools, having to manage young people who have ADHD as opposed to those that do not, and managing to give the same attention to both groups of young people can be challenging as well.
Yeah, it's really interesting. I remember when I was at school, I can think back now that I know about the diagnosis and the disease, if you like, and the definition of ADHD. I can think back to school where there were at least five or six of my friends who probably had ADHD. I probably had a bit of it myself because I struggled to concentrate at school and was always quite a high achiever at school. But I suspect now I might well be have a bit of sort of support around that area. My niece is a SEN lead in a high school in Northumberland, and there's the diagnosis and recognition of ADHD in children is a lot, certainly a lot more visible than it ever used to be. I wonder though if we've gone a little bit far the other way in some aspects where normal behavior with a little bit of I think a lot of people struggle with attention sometimes and sometimes boys and girls when they're young can be a bit naughty and a bit boisterous, and I wonder whether there's a little bit of over diagnosis of ADHD as well as underdiagnosis, Beryl. I don't know.
Yeah, there certainly is underdiagnosis, but the idea about overdiagnosis has many, many nuances in the sense that there are differences in terms of the services. I mean, I don't think I'm speaking out of turn if I say that if you had waited for a very long time to have an assessment of your child and then you decide to pay what is significant amounts of money to have it done, and then you go. There is a school of thought that says that some of the things that we perceive as overdiagnosis is because most people that wind up paying for their assessment and diagnosis end up with a diagnosis anyway. So is it a question of value for money, or is it a question of the fact that you have actually accessed a service because you have had no other choices, and the likelihood is that the suffering of the person that needs diagnosis is so much so that they risk a problem anyway, which is why the diagnoses are being arrived at. There are different difficulties around what you mentioned in normal behavioral challenges, but if clinicians follow the guidelines and looked at in their entirety, then you will realize that there is a lower risk of overdiagnosis than having underdiagnosis, because the guidelines are quite extensive in what constitutes ADHD and what doesn't, and where there are other comorbidities, when to do mental health assessments, and when to refer on to other services where other symptoms dominate over the ADHD symptoms. And a combination of those guidelines as well as the criteria, which are international, would mean that you only really be diagnosing people who are authentically ADHD.
Yeah, yeah. So that, and we'll come on to the guides in a minute, but there are some quite clear criteria for diagnosis within that. Just in terms of medicines then in ADHD, what are the particular challenges around the use of medicines in ADHD?
I think with regard to medicine, there are issues around supply. We all experienced a couple of over the last couple of years where there were supply disruptions, which needed input from all involved to support those who were living with ADHD. So those supply challenges have led to system-wide approaches, most especially platforms like the specialty pharmacy services that offer information about what's available, what isn't, access to medications, suppliers that have certain medication and those that do not. So I would say that the supply issues have more or less been addressed, even though there are pockets of issues every now and then. Medicines, a lot of ADHD medicines are controlled drugs. So the stimulants are controlled drugs. And that means that, you can't, there's an added complexity where prescriptions can often not be offered in a bulk. So you are restricted to a number of days of supply. And if you're forgetting to request them, then there are times when you do not actually request your medication on time. And if you forget to have your medication dispensed, then the prescription goes out, it expires because it has a 28-day validity and things like that. So logistical challenges when it comes to medication. And then when it comes to prescribing, there are other complexities. Like I said, the existence of comorbidities means that we cannot always rely only on ADHD medication to manage the symptoms that patients are presenting with. So there's that challenge for clinicians. And for patients themselves, the wide number of formulations that are available, even though we only have a limited category of medication that can be prescribed for ADHD in the UK, those medications are divided into several different formulations. So, for example, if you take methylphenidate, that comes as extended release tablets, extended release capsules. You have unlicensed or licensed liquids that come at a cost. And then there's an issue of what's in your local formulary and what isn't, based on cost effectiveness and things like that. So prescribers often have to look into not only what is first line according to NICE guidelines, but also in that first line, what formulation is allowed in my formulary. And then patients would obviously have other challenges, like if you have swallowing difficulties, what is best for you? Can your capsules be opened? And if they are opened, would they still give the same efficacy as if you are taking them whole? And things like that. And then often you need to speak to patients about when their symptoms are worse. So for children and young people who are at school during the day, what formulation is best for them? And then you have to be careful not to prescribe things that are too late during the day because stimulants can also have an impact on sleep, with some causing young people not to sleep properly and even adults not to sleep properly. So you have to time medication exactly to suit the patient. But then, on the other hand, ADHD in itself can be a problem in the sense that if you're not treating adequately, if the dose is not optimized, then it's wearing off quickly. And therefore, in the evenings, they are unable to power down and settle down. So you're wondering, should you give a tiny dose in the evening to help young people with homework, to help them manage symptoms so that they can listen, focus, do their homework, and then go off and relax and go to sleep. So there are certain challenges linked to medication that require expert experience and also requires a lot of knowledge around person-centered care.
Yeah, that's great, Bell. So there is guidance out there, but again, with all guidance, it's about not slavishly following it to the letter. It sounds like there's a real individualized aspect required here to make sure that the medicine is right for the individual within the broad recommendations of the guidance. So in terms of the guidance, and what is there out there for management of ADHD?
Well, I mean, the main guidance that all services use, and which I must say is quite comprehensive, and is the NICE guidance for ADHD, makes recommendations for psychoeducation, preparing. I mean, you have guidance about who should be managing people with ADHD, assessing, diagnosing, and then it goes down to non-pharmacological approaches and pharmacological approaches and things like that. I think maybe one of the glitches with NICE guidance is that even it would tell you that medication can be recommended for children as young as 5 years old, but the medications available are mostly only licensed from the age of 6 and above. So you need to think about that little gap between the age of 5 and 6 as to what is appropriate for that age. And then you have your NICE quality standards. You have the UK Adult ADHD Network, UCAN, which has comprehensive guidance. I think they've even got a free ebook, which is available as a PDF, which clinicians can diagnose and read, and it's very good. The British Association of Psychopharmacology, BAB, has ADHD guidance, which is very comprehensive around pharmacological care and also quite comprehensive when it comes to managing ADHD comorbid with other things like substance misuse, anxiety, and things like that. The only glitch with BAB guidance is that it was published in 2014, and I haven't seen that it has been updated recently. NICE guidance was 2018, but the recommendations, I think there's been recent updates, and I think they are very much up to date. You can look at other countries as well. I often tell clinicians to look at what's happening in other countries. Canada, for example, has very comprehensive guidance in their CADRA guidance. And even though it's hundreds of pages long, you can focus on the areas that you want. And they then have conferences that discuss updates to their guidelines and things like that. Then it will go down to things like Charity Foundation, ADHD UK, ADHD Foundation, which has high quality, accessible information and stuff with less, validity, but also provides a lot of support for clinicians. It's the professional peer support groups that they can access, where you have other clinicians you can discuss your cases with and get guidance on. And often it's quite helpful, particularly for those that are just starting off in the service.
Yeah, so I mean, I think there's two things there. There's the guidance constructed from the evidence from the clinical trials, which is what you'll get from NICE, as well as the sort of the consensus that fills in the gaps where perhaps there aren't clinical studies. And as you say, NICE guidance that there is an active surveillance team at NICE who will be looking to see whether the guidance from 2018, if there's anything that triggers an update, and if they haven't updated it, it's because there hasn't been anything that's come along that requires a consideration of a change to the recommendation. So I think people can be reassured by that. The last bit you said, which I'm fascinated by, is that sort of the stuff that you get maybe from support organisations or from other, so that address maybe some of the practical aspects of looking after people with ADHD. So, I mean, what practical advice would you have for clinicians who are looking after people with ADHD, or indeed carers who are looking after children and people?
I mean, it's different. I think for both carers and people who are clinicians who work with people with ADHD, it's about being able to listen to sufferers without judgment, because it is very frustrating for the person that has ADHD to have symptoms that they cannot control, or also for those that are looking after them not knowing what best to do. If someone is refusing to listen, if they are refusing to focus and jumping all over the place, it's also difficult. So it's everybody learning, and you can access forums for parents. There are parent support forums in most organizations where you have drop-in from clinicians that you can talk to about where your challenges lie. And then you get practical solutions around setting boundaries for children that are, there are a lot of issues that are around behavior, which is not always, as you said in the beginning, linked to ADHD itself. So if you're talking about children and young people who are undergoing puberty, it's very difficult sometimes to differentiate between symptoms that are because their ADHD treatment is not optimized, and because it is, changes due to puberty and things like that. And you can often have practical help to parents on how to manage that. But with clinicians, it's about not treating the prescription in isolation. So we've talked about, what is best for the young person. Is it sometimes appetite is an issue when you're prescribing medication for ADHD. So you think about, how to monitor a patient that is struggling to eat properly, when best to give them their medication, and what practical things you can tell families. So sometimes I say, look, if they're not eating, can you just give them stuff that they enjoy eating when they want to eat it? So there are times when, even though we are aware that there are certain things around diet that you have to be aware of when treating people with ADHD, particularly young people, sometimes you prioritize feeding them over just being very particular about what they are eating, and balancing that to ensure that they are getting fed, because ADHD in itself affects growth. The medication will affect growth. So being confident about the medication that you're prescribing, knowing the right range of choices that are there, and guiding families through making the right choice, through that shared decision making is important. Monitoring them. NICE guidance is quite comprehensive about what needs to be monitored, but often it is very difficult to follow through with the monitoring, particularly with the resource and limited services that we have, and also getting people to come and do those physical health monitoring that is essential to ensuring that you are prescribing safely is important. And then knowing when to signpost or when to refer. There are times when you're reviewing a young person or an adult that has ADHD, and you realize that despite all your best efforts, despite all the things that you've done to optimize their treatment, making different choices, making different alterations and switches, it is not working. And you need to drill down to where the actual issue is. And if it's something that you cannot manage, maybe because there is a complexity, there are other issues that are going on in the person's life that are influencing their response to treatment. You need to know when to seek support as a clinician, when to take those cases to a multidisciplinary group and discuss them, or look towards an expert colleague that you can refer the patient to. So it's important to know our limitations as prescribers.
Brilliant. I think that's really helpful. Again, that's just made me think of complexity theory here. So this sounds to me like the classic example of a complex problem rather than a complicated problem. And the thing about complex problems is you can't fix them. Sometimes what you need is just to try and help people a little bit to make their lives a little bit better. And the analogy is always between putting a person on the moon, which is a complicated problem. You can do it if you follow all the standard operating procedures, you press all the right buttons in the right order, you can put a person on the moon. But bringing up a child, or indeed managing somebody with ADHD, is a complex problem. You can't just follow a guideline, do the same thing over and over again and expect the same results. It requires that nuance, it requires that individualization, it requires an improvement, trying something, see if it improves, and if it doesn't, try something else. That's the key components to this. So I think that's really those practical aspects, I think, are the things that are really, really helpful here. And I suspect people like you and people who work in the clinicians who work, experienced clinicians who've worked in this field are worth their weight in gold to the parents and carers of people with ADHD. So, Beryl, that's been a fantastic conversation. Just to finish off, can I ask you what would be the three things you would say to clinicians about how to get up to speed with the management of ADHD?
I think collaborative working is really, really important. Having links between all the different services that are available so that we can support continuity of care. Often we are initiating medication in people in specialist services and expecting that this will be continued in primary care. And often there is not that continuous link between those services to ensure that if there are challenges in either sector, they are being communicated and dealt with to improve outcomes for the person with ADHD. So I would say that those working in there should maintain those links across the different care pathways and across the different sectors so that there's continuity of care for patients. And then do some structured learning. Sometimes we are so busy in clinic all the time that we do not free up time to actually educate ourselves about what is new, what is different in the field of ADHD. I went to a conference recently that was held in Hamburg, and probably one of the biggest conferences I've ever attended. Had like 2,400 delegates, and presentations on ADHD from people renowned in the field like Samuel Cortese, who would then share information about some of the research that they are doing, which is quite new, that would help clinicians in their everyday clinic. So go to something, go to a conference, do some structured learning, look at things like ADHD Foundation, which have their Neurodiversity University, which is free to access. Talk to patients themselves, attend some patient forums where you listen to patients who are themselves experts by experience. And I used to do something with patients years and years ago where you attend a patient forum and you have just a simple round robin where you talk to patients and ask them, what are your biggest challenges? And they'll tell you. And sometimes it's quite eye-opening for you who's working in that field to say, you thought this was a problem, but patients are telling you that actually that's not the problem I have. This is the problem I have. And you listen to them. And sometimes the problems are not about medication. They are around simple things like reward seeking, starting arguments. How do I support myself to do some of these things? And take along your colleagues that are occupational therapists, psychologists, and stuff to those forums. And patients themselves would benefit from it. And you benefit from it because you know when to prescribe and when to suggest something else that is not prescription related.
Brilliant. I mean, I think that there's three absolutely cracking challenges, I think, for clinicians and others there. That collaborative working thing, and it used to be there was that sort of breakdown when you transition when a person, becomes an adult. That transition from the CAMS service, which is often well designed and well structured, into adult services where they're maybe not so used to seeing people with ADHD. It sounds like that's getting better, but there are still areas of the country I know where that's still a struggle. The second one, absolutely, I love. When I'm teaching information mastery to people, what we say to people, like, you've got stuff in your brain, and that's how you make your decisions based on what's in your brain. But if what's in your brain is out of date and things might have changed, what are you doing to update your brain, to sync your brain with the latest evidence? And doing that once or twice a year seems to me like a manageable way of staying up to date. And the third one I think is brilliant. It reminds me a little bit of when we had Deb Gompertz on the podcast, who did this fantastic campaign called Show Me Your Medicines, where you think people are coping or you think people think certain things, but it's only until you ask them or you ask to see their medicines and how they use their medicines that you realize that your thinking is out of touch with their thinking, and what's important to them isn't what you thought might be important to them. And the only way to do that is by having conversations with people or to attend patient forums, as you say, and get that insight that you're not going to get anywhere else, Beryl. I think that's really, really helpful. Listeners, you'll be absolutely thrilled to hear that Beryl's going to be doing a masterclass for PrescQIPP on the 18th of August. So if that half an hour of Beryl and I chatting about all things ADHD wasn't enough for you, she'll be going into a lot more detail with some of the more technical medicines aspects of ADHD on that. So attend live on the 18th of August. It will be available to download and listen to afterwards for PrescQIPP subscribers. So we're really looking forward to having you for that masterclass, Beryl.
Yeah, I must say the masterclass will not just be on ADHD. It will be about safe prescribing in children and young people with mental health. And obviously we'll talk about ADHD, but there will be other aspects to it as well.
Even better. I think as you say, there's probably some generalized aspects around safe prescribing in children and young people with mental illness. And there will be some specific stuff around ADHD that we've discussed. But yes, really looking forward to that. Beryl, thank you so much for your time. That's been an absolutely fantastic, fascinating conversation. And thank you for listening. And we'll see you next month for the next Talking Meds. Bye. We hope you enjoyed today's podcast, and we'll see you next month for the next episode of Talking Meds from PrescQIPP, engaging conversations about medicines-related dilemmas. Please follow us on LinkedIn and Blue Sky to join in with the discussions, and email us at talkingmeds@prescripp.info with your feedback or suggestions for future topics or guests. Please don't forget to register for access to the PrescQIPP website and all our excellent resources.